All right, so this is hump week, right? We're over the hump now, and the midterm is over. I hope that everybody survived it in one piece. I expect maybe while you're listening to this, I'm still working on grades. Um, this week, one of the first things you'll probably notice that there's only one YouTube video or, narrated PowerPoint, and this one is even comparatively short. I know as I look back and I think, wow, week 4 was like twice as long as this. There just doesn't seem like a good place to break off and realign content. But, maybe at some point I will do a better job of that. But at least this week, and a few of them from here on out, actually, a little bit of a breather. So hopefully you can spend a little more time with it, feel a little bit better about the topic. This week is the management of pain, the pharmacology of pain management. And as you know, pain, it's a huge topic of conversation, in contemporary practice of patient care, where, of course, the opiate epidemic, the opiate, whatever you want to call it, all of this addiction, and then having to get people through addictions really is at the forefront of pain conversation nowadays. It's not my goal to have that conversation with you in this lecture. I may slip into it a little bit here and there, but what I want to do right here is just present to you as best I can the physiology of, and physiology as it relates to the pharmacology of pain management. Like, these are the classes of drugs we use to treat pain. This is how they work. And so from that perspective, you can analyze why some things will work better for some forms of pain and other things don't work as well for other forms of pain. And then, when you're considering your choices for pain management, of course, always one of the things, I know I've been saying this almost every week from week 1, it is a risk-benefit analysis. At what point does the benefit of the medication become worth the risk? And there is a time for opiates. It does seem like now nobody ever wants to prescribe opiates for anybody, anything ever. I don't know what your experiences are at work. I've seen people come out of the hospital with like major abdominal or major orthopedic procedures, which are extremely painful in their recovery, and they're coming out with 25 milligrams of oxycodone, or hydrocodone, not even oxycodone, which, once upon a time was what you would give people for a toothache. So I'm not necessarily suggesting we should get everybody, with a toothache, 20 of hydrocodone, but there does seem to need to be a middle ground that the pendulum will swing back to. And hopefully you can use some of the information in that unit when you're the one deciding, who gets what for what kind of pain. It always troubles me just a little bit to see people adhere strictly to an algorithm, strictly to, here's the list, this is what you had done, or this is your injury, this is what you get. Always remember that if all we had to do was follow an algorithm, we wouldn't need any brains to do the job. The brain comes in where you take the algorithm as a guideline and then, decide how and when to deviate from it. I know I sound like I'm saying opiates for all, which I'm totally not, but just cautioning you that the pendulum does seem to have gone a hair too far in the conservative direction, and I'm certainly not the only one saying that. But hopefully you will use the medication in this slide set, or use the information in this slide set to help you figure out where to go from here when you're having to manage people for pain. Okay, so I guess enough of my soapbox here. Let's get to it. So as always, if you understand the physiologic phenomenon going on, then you can think about better how drugs are used to manipulate that physiology for a better patient outcome. So before we talk about the pharmacology of pain, we need to talk about the physiology of pain. And what I'm presenting here to you is the foundation. It's the very textbook foundational, like what we all know about pain, like what all the authorities agree. Beyond that, there certainly is a lot of differing opinion in the world of pain physiology, and not everybody agrees with every theory. That will be for you to decide when you finish school and you go into your area of practice expertise. But what I'm presenting to you here now is the foundation. It is the hard and fast stuff that has been very well supported in the evidence, and everybody agrees is, these things are going on. So then we decide how to stick drugs in there to fix it. I will spend a little bit of time at the very end of this slide set talking about the management of migraine pain, because it is really unique. There's probably a lot of different pain phenomenon that you could pull out and say, well, this is unique and we use unique medications for this too. And I guess if we did that, the slide set would be as long as every other. And I don't think that's particularly instructive here. So I just feel like our best bet to get you the most out of this week is to talk about the stuff that we all know, we all agree on, and then just because migraine is rather unique and it is so prevalent, and because there are several new classes of drugs in the migraine world, I actually added a few slides to this that I haven't done previously. So, and then we'll be done. Okay, so the pathophysiology of pain basics. These are the things that are universally acknowledged in the world of pain management, that there are 4 distinct processes that contribute to, from the time something happens to the time that your brain processes a pain signal and then decides how to respond to it. And those 4 things are transduction, transmission, perception, and modulation. There are varying interventions, varying classes of medication that can impact each one of these. And so many times when we combine classes of medication, it's because we're giving one that can impair, or not, I guess impair is not the word, we're giving one that can change transduction, perhaps one that can change transmission, and so forth and so on. So transduction, transmission, perception, and modulation. And transduction is when the stimulus is converted into a nerve impulse. So if this is, just, using the example of an external injury, say you slam your finger in the door, the kinetic energy of that door pushing on your fingertip is a stimulus. And then there are nerve endings in your finger and in your vasculature, a bunch of nerve endings that are going to receive that stimulus and convert it into an impulse. And that's transduction. So is there a way that we can interfere with how the stimulus is converted to a nerve impulse? Of course there is. Transmission is when that impulse goes to the brain. So this is a different piece of the conversation. Transduction creates the nerve impulse. Transmission carries it to the brain. Once it gets to the brain, it has to be perceived. And there are numerous other things that will impact perception. And then finally, modulation. What else is going on in your brain? What else is going on in your body to augment the way that you perceive that transmission? And all of this can go in multiple directions. Some of these can go wrong and exacerbate pain. Some of these can go right, I guess, and inhibit the sensation of pain. But these are the 4 steps: transduction, transmission, perception, and modulation. I know that those of us that like to memorize things always feel good about, rattling these off, but keeping in mind, it's not just so much that I want you to be able to regurgitate transduction, transmission, perception, and modulation. I do want you to understand what they mean. Transduction takes the thing, whatever it is, the stimulus, and converts it into a nerve impulse. Transmission carries that impulse to the brain. Perception is how other messages help you interpret that impulse, and then modulation is what your body's going to do that will impact the way you perceive it. So those are the 4 general pieces of the pathophysiology of pain. So first thing we have to do is transduce it and then transmit it. So you know that we have free nerve endings that are all over the place in tissue. They're all over the place, all over the body. And these are receptors. Remember when we talked about the neuron in week 4, and we talked about how dendrites are extended out like tree branches into the environment, and they will perceive some sort of trigger, some sort of stimuli, and some are excitatory and some are inhibitory. Well, those things that can cause pain generally tend to be excitatory. And of those nerve endings that are distributed all over the body, the pain receptors come in 2 general types: fast pain receptors and slow pain receptors. Fast pain receptors do exactly what the name implies. From the time that stimulus is transduced into an impulse, and that impulse is transmitted to the brain, it is less than 0.1 seconds. This pain is perceived as, just like the slide says, sharp, acute, very localized, electric. I'm trying to find a way to not read your slide to you, but this pain is just immediate. It's just immediate so like if you slam your finger in the door, immediately, before part of your brain even knows that you slammed your finger in the door, you can feel it. This doesn't happen so much in deep visceral tissues in the body. There's a little bit of that, but it tends to be more superficial. This is associated with destruction of tissue, whether it's acute, like slamming your finger in the door, or like it's anoxic, if you like have impaired blood flow to an area. This type of pain tends to be associated with tissue destruction. And really the role of fast pain receptors is to get the message to the brain that some part of your body is being injured right now, and you need to remove that part of the body from the thing that is injuring it. The primary purpose of fast pain receptors is to get a sharp, immediate, acute message to your brain within 0.1 seconds of the bad thing happening so that you can know exactly what's being hurt and you can withdraw it from the pain-inducing stimulus, like open the door and get your finger out of it. So those are fast pain receptors. We also have slow pain receptors. Slow pain receptors, again, the name gives it away here. Here you don't feel the pain for greater than 1 second from the time of the stimulus. And I mean, even though it sounds fast, it's not in the world of something injuring your body. Like if you slammed a door on your finger and you left like that slam in place for 1 second or even a little more, it can do a whole lot more tissue damage than if you remove it within 0.1 seconds, right? So the purpose of slow pain receptors is not to transduce and transmit the stimulus so that you can remove the body part from the site of injury. This is to remind you that something is injured so that you leave it alone and rest it. Like for instance, you slam that finger in the door and immediately your fast pain receptors will send a message to the brain right away that something really bad is happening to your finger, get it out of there. So you open the door, right? And you pull your finger out and you go, oh man. And then you look at it and then you start to just begin to feel that throb and you're like, oh man, this is gonna really hurt. This is gonna hurt. The worst of it wasn't how it felt when you slammed it in the door. The worst of it is coming like over the next many hours. And depending on how bad the injury is, it could be 24, 48 hours or something. And it's a different kind of pain, right? That burning or throbbing, aching, deeper kind of pain. Sometimes that pain can make you nauseous. I'm sure that all of you that are listening can identify with the two different types of pain I'm talking about here. Fast pain receptors and slow pain receptors, right? Fast pain receptors, like the name says, you're going to feel it in less than 0.1 seconds of the time of injury. The job is to alert you to the fact that something is hurt so that you can remove it. Slow pain receptors takes comparatively 10 times or more longer to feel the pain. The job of slow pain receptors isn't to give you the immediate signal like, hey, get your finger out of the door. The job of slow pain receptors is to say, you know what, this tissue is injured. You need to rest it. You need to leave it alone. Let it heal, because there is nothing for injured tissue repair than just resting it for a while. So what do? We just take a bunch of Motrin and use it anyway, and that's why it takes so long to heal. So slow pain receptors is going to take a little longer for you to feel it, but its job is to say, hey, this something is injured here. Please just rest and leave it alone. So pain receptors, you've got fast pain receptors and slow pain receptors. They are all free nerve endings. This is where transduction occurs. And they are all over the body. I mean, if you have a healthy, normal functioning body and any part of it gets injured, you're going to know it. You're going to feel pain. Different parts of the body are going to present with different types of pain, and this isn't to say that they're mutually exclusive. Very often, you'll feel both types of pain from one injury, although not always. Sometimes something that might be very superficial is just perceived by a fast pain receptor, and sometimes when a bad thing is occurring deep within the body, all you'll get are the slow pain receptors. And many times they will occur together. Pain receptors are distributed all over the body. They tend to be much more voluminous in bone, in skin, in peripheral structures, whereas like in the organs and the viscera of the body, the pain receptors tend to be distributed more sparsely, and then they feed into a central pain network. That's why very often deep pain, you can't really localize it. Like think of an MI, right? People have angina or an MI, and they can't say it hurts right here and point exactly to where in their heart it hurts. What they will tell you is like maybe the left side of their chest hurts, or they have epigastrial discomfort, or sometimes it's their jaw or their arm or whatever. It's because those deeper visceral organs, you can't remove them from the stimulus, right? There's no point in having a bunch of fast pain receptors in your heart because it's not like you can say, oh, let me get my heart out of there. The only real point of having cardiac pain is so that you will rest and try to give it a chance to heal. So anyway, fast pain receptors and slow pain receptors. The distribution, in part, is what's responsible for how you feel the pain. Some pain you can localize very specifically, and other pain, like you're lucky if you can figure out which quadrant of the abdomen is really bothering the patient. So we said that pain receptors are responsible for transduction, and we said there are fast and slow types. And we also said that there needs to be some stimulus that is then transduced into a nerve impulse, right? So here we are introduced to the different types of stimuli, and there are 3 general types: mechanical, thermal, and chemical. Mechanical obviously is like the finger on the door. This is when something, crashes into a part of your body and it really hurts. Thermal obviously are extremes in temperature, not just hot, although heat is the thing that comes to mind, but very, very cold, frigid temperatures can cause pain as well. And then chemical, mostly we're talking about the chemicals that are released from the intracellular environment when cells die. Note, especially important in slow suffering pain. So if you really want to have some slow suffering pain, you've got to have some chemical stimulation there. Now think about it. Mechanical stimuli and thermal stimuli do tend to be more superficial, right? I mean, you're more likely to encounter them outside of the body, whereas chemical pain, in other words, the chemicals that normally housed in the intracellular environment, and then cells die and they are spilled out into plasma, those tend to occur more often inside the body. So mechanical and thermal stimuli are more readily perceived by those pain receptors that are distributed more superficially, like in the skin, for instance. I mean, not just the skin, but that's an excellent example. Whereas the receptors that are triggered by chemicals tend to be deeper. Here's some of the chemicals, right? You'll recognize all of these as intracellular contents that are liberated into circulation when cells die. So some of them you'll probably recognize, like potassium. I'm sure I've said this more than once in the course of conversation to remind you that the intracellular environment has like 140 milliequivalents of potassium, whereas the extracellular environment has 4. I'm sure you might have been told that if you infuse potassium in too heavily concentrated a solution, it burns the vessels. That's why we never give K boluses like just a syringe full of potassium, right? It's why you have to dilute it in a fluid and then hang it as a K rider, because potassium is very irritating. Acid, of course, remember, the intracellular environment has a pH of 7.0. The extracellular environment has a pH of 7.4. So if cells die and all of those hydrogen ions spill out into plasma, it's going to burn. Substance P is a classic pain neurotransmitter or pain chemical. Serotonin has many roles. We talked about it quite a bit in week 4 as it relates to mood. Histamine we see all over the place, but these are, and prostaglandins for sure. These are all things that are contained in the intracellular space, and when the cells are damaged, they are released and they can activate slow pain fibers. So then what? So transduction, we said, is from the time that stimulus, let's see if my little drawing thing will work here, from the time that stimulus is perceived by the nerve ending and converted to an impulse. Now remember, like we talked about in week 4, you've got the neuron or the nerve cell, and the nerve cell has dendrites that perceive all sorts of stimuli from the periphery. So the littler red circle, if I can manage it here, the littler red circle are dendrites. So they're the receivers, they're the antenna. They are picking up whether it's mechanical, thermal, prostaglandins, serotonin, potassium, whatever it is. They're perceiving the stimuli, and then they take it down to the cell body. Remember, the cell body is where the nucleus is and all the organelles, and they convert all of these stimuli into an impulse or not, right? There will be a summation of excitatory impulses or inhibitory impulses. This is how you convert banging your hand in a door or spilling a bunch of potassium ions into a nerve impulse. It happens in the cell body of the neuron. That looks here like, I don't know what that is, but we'll circle that too, where it says soma. That's transduction. So mechanical, thermal, and intracellular chemicals, and some of them come from the extracellular environment too. These are all the things that can activate nerve endings and contribute to the conversion of a nerve impulse. Then this impulse has to travel to the brain, right? This is transmission. So although all pain receptors are free nerve endings, as the slide says, these nerve impulses utilize pathways to get up to the brain. And there are two distinct pathways that are implicit in transmitting pain signals to the central nervous system. Those two pathways are called the neospinothalamic tract and the paleospinothalamic tract. So the first one that's described here is the neospinothalamic tract. Again, the name tells you exactly what it does. Neo means new, and the new refers to when it occurred during fetal development. So neo is new. This occurs comparatively later in fetal development. I mean, it's still like, early in the first trimester, but it's comparatively later, meaning a lot of the central nervous system is already developed before the neospinothalamic tracts emerge, and that does become significant later. So the neospinothalamic tract is the tract, it is the pathway by which the impulses transduced by fast pain receptors are translated or transmitted to the central nervous system. We refer to those fast pain receptors as type A delta pain fibers. Type A delta pain fibers and fast response is the neuron. The pain fibers that contribute to the neospinothalamic tract are type A delta pain fibers. I mean, I know I'm probably just getting too confusing you here. The bottom line is, when you think about this process, think fast pain receptors / type A delta pain fibers basically as the same thing. There are very subtle differences that aren't worth perseverating on here. Fast pain receptors / type A delta pain fibers, that impulse is carried to the brain by way of the neospinothalamic tract. New spine to thalamus. Remember, the thalamus is like command central in the brain. It's where an awful lot of input lands, and then the brain farms it out and sends it where it needs to go. Neospinothalamic, new spine to thalamus tract. And the neospinothalamic tract is comprised of type A delta pain fibers. These are the fibers that transmit mechanical and acute thermal pain. So the pain is transmitted very fast. You can see of speeds of 6 to 30 meters per second. That's fast. These are the impulses that are going to get to the brain in time for you to preserve tissue. Because, excuse me, because this spinothalamic tract emerged comparatively late in fetal development, and most of the central nervous system was already put together, these fibers pass all the way to the thalamus. These impulses get to the thalamus intact. So these intact impulses can be localized very precisely by the thalamus. And this is significant, keeping in mind that type A delta pain fibers serve largely to alert the brain to the fact that part of the body is in trouble and it needs to be removed from the bad stimulus. If you get the message to the brain very fast, you can protect whatever part of the body is being hurt by removing it from the bad thing very quickly. It's important to localize it precisely. If you can't localize it, you can't really protect yourself from it. Let me give you an example. If you ever got a tiny little sliver of glass, like say you dropped something and a little microscopic little piece of glass was left on the floor and you didn't know it and you stepped on it. Or you're out walking around like a deck and you get a little tiny, splinter in the bottom of your foot. You know exactly where it is, though, don't you? This is very superficial, right? It's just in far enough to irritate pain fibers, and it's going to be irritating type A delta fibers. You know immediately. You get a splinter, you know it right away. You know it before you can even see it. You get this pain and you look at it and go, oh man, do I have a splinter? The answer is yes, you do. If you're having that thought, it's already there. So it's very, very localized. You know exactly where it is. Then maybe you'll get like a magnifying glass, or you'll get your glasses and turn on the light and shine it like on your foot or wherever, and you're like diligently looking for this thing because you know exactly where it's supposed to be. Or maybe you get somebody else, you give them like, give them your tweezers and a magnifying glass, and you're like, oh, it's right there, get it out. And they're like, I don't know, I don't see anything. And you're like, it's there, I know it's right there. These are your type A delta pain fibers. They want you to get that splinter out. Or if you've ever been, I'm trying to remember if you have a lot of mosquitoes, but I haven't lived back there for like almost 20 years. Yeah, you got mosquitoes because you have a lot of water. Or a bee or something. Like say you're like just out back and you're barbecuing and whatever. It's like a spring evening and life is good and you get stung by a bee, like on the back of your thigh. You know immediately, like you might not even know what it is, what bit you, but you know immediately and you know exactly where it is. You can reach around and smack it to kill that thing before you even know what it is because it is so precisely localized. That's getting to the pain, that's getting to the brain by way of this neospinothalamic tract. And its job is to protect you so you can get rid of the stimulus. Very fast, right? 6 to 30, meters per second. The paleospinothalamic pathway is very different. Paleo, very, very old, right? Paleo is ancient. Paleospinothalamic pathway emerged very, very early in central nervous system development. Like a lot of the other nervous system wasn't even developed yet when the paleospinothalamic pathway emerged. So the problem is, since the rest of the nervous system had not developed well yet, these fibers don't get all the way to the thalamus uninterrupted. You can see by your slide, only 10 to 25% of these fibers actually make it to the thalamus. Most of them terminate earlier in the brain stem. Couple things that are significant here. Number one, this is this pathway by which type C fibers carry their message to the brain, and the type C fibers are your slow pain fibers. These are the ones, these are your slow pain receptors. These are the ones that are activated by acid, prostaglandins, potassium, etc. And so their job isn't to alert you to the fact that you have to remove something from a painful stimulus. Very often at this point, you can't remove it. All you can do is be alert to the pain and do whatever you need to do to try to relieve it, which in the case of angina is going to be increase oxygenation, decrease workload. In the case of, I don't know, a sprain or a strain or a break, it's going to be stop moving, rest that thing. So it's a whole different role here. Paleospinothalamic, very old spinothalamic pathway. Most of these fibers don't make it to the thalamus, so you can't localize the pain well at all. This is what we were talking about before. You don't know which part of your heart hurts. You just know that like some general thing on the left side of your body from the waist up is very uncomfortable, right? That's all you need to know, because that's going to make you relax and take a break, and that's what your heart wants you to do. And again, these are not mutually exclusive. If you just get stung by a bee, well, no, it's a bad example because they can really hurt. Say you just get like, stung by a mosquito or some little fire ant or something bites you, all you do is trigger your fast pain fibers. You're alerted, you smack away the ant, it's gone, end of story, right? You don't have any pain after that usually. If you get a bigger mechanical injury, like slamming your finger in the door, not only do you want to remove your finger from the thing that's hurting it, but then you need to allow it to rest while that tissue heals. So you will have both type A delta and type C fibers firing off on that finger. Immediately, the type A delta fibers try to get your finger out of the door. And then for the next several days, your type C fibers will say, hey, stop trying to use me. Don't push me against stuff. Leave me alone until I can heal. And then sometimes all you'll really appreciate are type C fibers, which would be the case, for example, with an MI. All right, so now we're talking about transmission, right? We've talked about transduction, mechanical, thermal, chemical, are received by either a fast pain receptor or a slow pain receptor, transduced into an impulse that will be carried to the brain either by way of the neospinothalamic pathway or the paleospinothalamic pathway. The neospinothalamic pathway carries the impulses that were received by the type A delta fibers. The paleospinothalamic pathway carries the impulses that are received by the type C fibers. Now they're traveling up the spinal cord and up through the reticular formation of the brain. So the reason the reticular formation is important is because the reticular formation, it's in the brainstem, and it's critical with respect to arousal, right? It's important with respect to arousal, wakefulness, sleep. That's why if you are in severe pain, it is very difficult to sleep. Think about one of the first things that we ask people when they have abdominal pain or chest pain or head pain or whatever. We ask if it awoke them from sleep. Because if you're not able to sleep through it, then that does imply that there is a very strong paleo-spinothalamic involvement there, which is your type C fibers, and that implies that there is a more visceral origin of the pain. There are people who completely sleep through pain, and that pain usually it just isn't that deep. And the reason is that the reticular formation, we're going to look at a diagram in a minute, in fact. Let's hold that thought. Let's look at some pictures. Pictures always make it easier to get the picture, to get the picture, no pun intended. But we'll leave it here. Person in severe pain is usually strongly aroused. They're hypersensitive to everything. Like they're hypersensitive even to loud noise or bright lights or anything like that. And it is impossible to sleep when you are in severe pain. And it's because of the way these pathways move. So yeah, let's look at a picture. Or even let's look at two. Let's see. So this shows you how the pathways cross the spinal cord. So you can see if you look on the left side, right? The left side of the screen as you're looking at it, and you see at like the top left, type C and type A delta. I mean, it doesn't distinguish them for you, but they're feeding in here. So type C and type A delta are coming into their own pathways. And, again, I know that you can't see it there. They're sort of farmed out in the spinal cord. And then there's a couple of particular tracts highlighted here, like the tract of Lesueur, the substantia gelatinosa. These are just very strongly associated with pain transmission. But the point I want to make to you is, I'm going to circle it in a little blue thing here. You see in blue, I'm circling your type C and your type A delta pain receptors are feeding in to the spinal cord. And then you see in the spinal cord, they are processed into their pathways. And then let's look at the yellow, where I'm circling in yellow, fast pain and slow pain fibers come out by way of these two pathways. They're not labeled here, but the fast pain fibers, this is your sharp, quick, localized pain. That is the neospinothalamic pathway. I'll call that a little yellow 1. And the slow pain fiber, the slow pain receptors go through the paleospinothalamic pathway, which we'll label as 2. It's a fancy 2 in yellow. And then they go up to the brain. Over here, now at this diagram, as you're looking to the right, on the bottom, you see the pain tracks. Again, they're not broken out here. Where is my... Okay, got a new mouse. This will work. So you see the pain tracks down here coming in. So you got yellow, like these are the same pain tracks. I'm drawing an arrow. This is just a blown up perspective as they come into the brain, right? So the pain tracks come up. Notice that they go through the reticular formation. And you'll see a couple of arrows here. And actually, you'll see it better in the next picture. Again, they're bundled here, and the neospinothalamic and the paleospinothalamic tract are not separated here. But what you do see in the reticular formation is a couple of little arrows shooting off here. The significance of that is this. Let's look at the next slide. Okay, so now you see the pain tracks coming up to the brain. So here at the bottom, I'll circle it in yellow, the pain tracks that we saw on the other slide, now they're coming up to the brain. Notice how you see a solid line. See how you've got the reticular formation, which is here in the brainstem, and you've got a solid line coming through the reticular formation with little arrows shooting off of it. Notice that as you approach the thalamus, these pain tracks break off into 2 branches. One of them is a dotted line before it gets to the thalamus, and the other one isn't. The other one is a solid line as it gets to the thalamus. The slow pain fibers are the ones that break apart before it even gets to the thalamus, and the slow pain fibers are the fibers that are starting to discharge little bits of impulses through the reticular formation. These little, I'm going to circle them in blue. These little arrows that are coming off here of your pain tracks, I mean, I won't circle all of them because it gets confusing. But all of these little arrows in blue circles, those are from the slow pain fibers. You're stimulating the reticular formation. Notice that the fast pain fibers, that line makes it all the way up to the thalamus completely intact. And then again, the thalamus is command central. It processes that input and farms it off to exactly which sensory area of the brain it needs to be. That's why fast pain receptors allow you to localize pain so beautifully and slow pain receptors do not. It's also why slow pain fibers are the ones that tend to keep you awake at night, whereas if you just stimulate fast pain fibers, you can sleep all the way through it. It doesn't drop off in the reticular formation. Best example I can give you is if you've ever been out camping or something and for whatever reason your mosquito protection's not good, and in the morning you wake up and you got bug bites all over you, and you might even have scratches all over you because you were scratching. You don't know it, you don't remember it, it didn't wake you up, but your fast pain receptors during the night were letting you know that something was like biting at you and trying to irritate your body. Whereas pain deep within the body or activation of slow pain fibers will keep you awake. If you ever want to try this out, just for fun, like if you're sleeping with your significant other, grab a fork and just poke them with it a little bit, just lightly. Don't break skin or anything, but just give them a few good pokes during the night. They will smack it and they'll roll over, and like that part of their brain is reacting to it, but they never even wake up. Whereas if you like hurt them really badly, then they will wake up. And I do not suggest that you do that, but it's true. If you poke them with a fork or poke them with a toothpick or something, just like poke, or just pinch them or something, their body will react. The pain, the stimulus to their brain will be through fast pain receptors, and the brain's like, hey, I got to get rid of whatever's annoying me here, but it doesn't actually wake them up. So that is transmission. Transmission happens by way of the neospinothalamic and paleospinothalamic tracts. Now, perception is something entirely different. Remember I said there are 4 parts of the physiology of the pain experience, right? Transduction, transmission, we've already talked about. Perception is next. Perception is how that transmitted impulse is perceived in the brain. And I mean, there's all sorts of things that can influence it. Physiologic factors, like being well rested, right? Already being in pain, because you can have heightened sensitivity. Psychosocial factors. Are you depressed? Are you anxious? Are you happy? Are you euphoric? Are you scared? People can experience the same stimulus very differently depending even just on their mood. Like imagine, for instance, that you're sitting in a classroom and you've got your feet like under a table that's too small or something, and your legs, and somebody walks in the room and says, oh my gosh, who's got, the red Honda Accord outside? Somebody just totally smashed into it and totaled it. And it's your car. And you go to jump up and you bang your knee under that table so hard, and it hurts so badly. Part of why it hurts that badly is because you are really upset that somebody has just totaled your car. You could be sitting at that same desk with the same space constraints and the same knee, and everything is the same. And somebody walks in and says, hey, who has that red Honda Accord? A random drawing, you've won $1 million. And you go to jump out of that chair and you bang that knee just as hard under that desk, like just as hard. You're not even going to feel it, right? You barely even know. You'll just keep moving because you just won $1 million. And there's all sorts of other things going on now in your brain to influence it. So, like, all joking aside, if you are angry, sad, depressed, not well rested, physically ill, or any host of other things, annoyed, whatever, that will influence your perception of a stimulus. Whereas if you are happy, well rested, uplifted, whatever, the very same stimulus could happen to you in the very same physiologic way, but you will feel it very differently. That's what perception is. And then, of course, there is modulation. What does the brain do to attenuate the pain? I'm sure most of you have heard of the gate control theory of pain, right? I mean, the gate control theory alludes to, I should actually put a link to that in your readings. I don't know that I have. The gate control, although it may be in your book, the gate control theory of pain alludes to the fact that pain, you have transduction from those peripheral receptors and then transmission through the spinal cord and ascending up to the brain. And then your brain actually produces neurotransmitters that block the ascension of the pain impulse or attenuate the pain, and that would be modulation. So messages come down from the brain to inhibit the ascension of the pain impulse. What does your slide say? Messages from the brain can suppress the pain signal that would otherwise be sent, yes, from the dorsal horn. Dorsal horn is like pain central in your spinal cord. So modulation is physiologically what your body does. This is really primarily neurotransmitters, what your body does to block the ascension of the pain. I mean, there is, an old philosophy that your body will never allow you to perceive anything that you can't handle. And that may be part of what modulation is. But I do want to emphasize modulation and perception are different things. Modulation is a direct response of your brain to the fact that pain impulses are on the way, and the brain will respond with suppression neurotransmitters. Perception relates to how completely unrelated things impact the way your brain processes those impulses. So here's what's going on. You see coming up from the spinal cord on the bottom of this picture, you see pain. The pain fibers contribute to the spinal cord. They're coming in from the left. They go into the spinal cord, and then they come up by way of the pathways. So pain is on the way up. The nerve impulse is on its way up. Your brain then will produce attenuating neurotransmitters, which are generally referred to as serotonergic and enkephalins. So serotonergic neurons and enkephalin neurons will produce neurotransmitters that actually block the ascension of pain. And this is basically what the gate control theory is. How much of the pain in your spinal cord is your brain going to allow in? You do need some. You need some pain to protect you and let you know something is wrong, but you can't take too much or you'll, pass out or something. So endogenous pain suppression is what comes down from above, and I'm going to circle them here in yellow. The enkephalin neurons, the serotonergic neurons, and you see them up here as well. These are producing neurotransmitters that are going down that will block. I'm really not good at drawing. What do you call it? Arrows. I'm trying to draw a yellow arrow here. Enkephalin neurons, serotonergic, and they all go down to try to block the ascension of pain coming up. So I think these next few slides probably narrate what I just tried inartfully to illustrate here. Endogenous pain suppression. So yes, neurons in the periaqueductal gray. I can't back up a slide here or I mess up everything, but you can back it up, I think, if you want to. Endogenous pain suppression happens because neurons up in the periaqueductal gray, up in the upper brain, the third ventricle, they basically send signals down, and they send them down to the spinal cord, and it's just about, you got impulses trying to come up, and you got suppressors going down. Who's going to win? How much is going to get up? Because pain isn't really pain unless your brain feels it. Analgesia signals can block the pain signals from arriving from peripheral neurons. So these are your endogenous pain suppressors. These are your enkephalins. Some people refer to them as endorphins. So these, again, enkephalins and serotonins, these are the things being released in the brain, working their way down. And you'll notice that these can inhibit pain from both type C fibers and type A delta fibers. So remember, type A delta fibers and the neospinothalamic pathway conduct the impulses and conduct pain from mechanical and thermal stimuli. Type C fibers perceive chemical stimuli and conduct it up the paleospinothalamic pathway. This endogenous suppression that occurs in the brain, these enkephalins and serotonins, these can block the ascension of both types of pain. They don't, natural pain suppressors don't usually completely block it, although some people are definitely better at doing this than others. There are some people that are just like living examples of enkephalins. Actually, there was a lady, it's been several years now since I saw her. I forget even where I was working, some outpatient world. And this lady came in and she was having, I want to say, a migraine or something. Anyway, she had the most horrendous medical history in terms of pain. And yet she was like so happy. Like she was just really, really an uplifted, upbeat, happy kind of lady. And I said to her, like, my gosh, you must have the most aggressive enkephalin system. And she said, it's so funny. My doctor said that apparently she was being treated. She was in Las Vegas on vacation from somewhere back east, but she was being treated by a husband and wife physician team. And one of them was really into Western medicine and one was really into Eastern medicine. So, good old fashioned pain medicine and the regular stuff. And then the non-traditional Eastern kind of medicine. And she said that they told her that she just had a great deal of natural enkephalin production, which protected her from pain, but also you had to be careful because she might not experience the level of pain necessary to alert her to the fact that something was really wrong. She was just a stunningly happy lady. When you think about your typical patient with chronic pain, stunningly happy isn't usually the phrase that comes to mind. And when you see that, you probably can assume that to some extent, they just have a really aggressive, highly functioning system of endogenous pain suppression. I think I'm repeating myself again here in these last few slides. We've already established pretty much beyond a reasonable doubt then that the various types of stimuli are conducted to the brain, and then these pain suppression neurons can drop neurotransmitters to control the ascension of the pain stimulus. So I guess to summarize, let's see. Let's go to the summary slide. All right, so it's not exactly a summary slide, but let me try to summarize it here for you. You have two primary types of receptors. Well, actually, before I even say that, let me summarize. Let me start from here. There are four distinct steps to the appreciation of pain, right? Transduction, transmission, perception, and modulation. Transduction happens at the free nerve ending, the most distal nerve, whatever part of the body we're talking about, the most distal nerve in that part of the body. It takes an impulse and transduces it, and it takes a stimulus and transduces it into a nerve impulse. That stimulus can be mechanical, thermal, or chemical. It's transduced into an impulse then that has to be conducted to the brain. It has to be transmitted. Fast pain receptors, and we've already talked about what their job is, fast pain receptors will conduct pain by way of the neospinothalamic pathway. It gets to the thalamus very fast, and it gets to the thalamus intact, so the thalamus can farm it out to exactly where it's supposed to go, so that you will know exactly where you are hurting. The paleospinothalamic pathway conducts impulses from type C fibers, from slow pain receptors. Most of them don't make it to the thalamus intact. So you can't exactly know exactly where it hurts, but you get enough of a message to tell you that a certain part of your body is in trouble and it's time to rest it. You also remember that the paleospinothalamic pathway begins to terminate in the reticular activating system, and that's why it's so hard to sleep when you have that kind of pain. In any event, these two pathways will get to the brain, and then how those impulses are perceived is influenced to a fair extent by other factors completely separate from the pain system, like your mood, your level of rest, just all kinds of stuff, bad news, good news, whatever. And then modulation is what your body does to try to attenuate that. And modulation largely is centered around the fact that there are certain areas of the brain, like the third ventricle, the periaqueductal gray, that have these enkephalin and serotonergic neurons that produce enkephalins and serotonins that move down toward the spinal cord to block the ascension of those pain impulses. And some people's work better and some people's work not so good. This is why biofeedback is really an important part, like the non-pharmacologic piece of pain management. You're trying to maximize these endogenous modulating responses, and some people are extremely good at it. However, at some point, something's probably going to get to the brain, and then you're going to feel pain, and that's when we have to start thinking about how we're going to manage it, which is pretty much like phase 2 of this discussion, which is the pharmacology of pain management. Okay, so with respect to the pharmacology of pain management, we're really looking at how drugs can interfere with those processes, or how they can, I keep saying interfere and I don't like that word, how medication can augment transduction, transmission, perception, and modulation to try to make the pain experience for people tolerable. I mean, we rarely completely eliminate it. Sometimes we get lucky and we do, but in the world of pain management, if you can reduce somebody's perception of pain by 50%, so if they start out by saying their pain is 10 on a scale of 1 to 10, if we can get them down to 5, that's considered a success. So let's look at how some of our common drug classes can do that. So the first class here are the nonsteroidal anti-inflammatory drugs, and there's a list here that is not meant in any way to be all-inclusive. It's just some examples. There are a ton of nonsteroidals on the market. I'm sure you're familiar with some of the more common ones like ibuprofen, which is marketed as Advil, naproxen, which is marketed as Aleve. I couldn't think of it for a minute. Good old-fashioned aspirin. Ketorolac is marketed as Toradol. You'll see that there's one here that has 3 asterisks next to it. That's the reason it has asterisks is that it falls into the category called COX-2 inhibitors or cyclooxygenase 2 inhibitors. There were several on the market at one time, but this one, celecoxib, which is marketed as Celebrex, is the only one remaining on the market, and there is a little bit of significance there. So again, this is just a representative list, not meant to be all-inclusive. The gist here is these are non-steroidal anti-inflammatory drugs, aka COX inhibitors, just because in science we have to have 5 different names for the same thing so that everybody can be confused. So what do non-steroidals or aka COX inhibitors do? So cyclooxygenase is it's an enzyme that is critical in terms of converting precursor compounds to active compounds in the body. So when we say that non-steroidal anti-inflammatory drugs, their mechanism of action is they covalently modify cyclooxygenase 1 and cyclooxygenase 2 pathways. Covalently just means interfere with bonds. Remember from basic biochemistry that virtually all compounds in the body are an assembly of bonded elements like carbon, hydrogen, oxygen, etc. I think we talked about this in week 1. We were talking about cytochrome P450. So cyclooxygenase inhibitors, aka nonsteroidals, they modify these bonds. They change the bond of some of the precursor compounds and change things up. So we have nonsteroidals that can modify cyclooxygenase 1 and some that can modify cyclooxygenase 2 pathways, and many modify both. So the difference between the two is that cyclooxygenase 1 is a constitutive pathway, cyclooxygenase 2 is an induced pathway. And I'm sure right about now you're saying to yourself, Self, what does that mean? Constitutive means it's always there, it's always happening. It's just a normal part of physiology. It doesn't need to be triggered or incited in any way. Induced means that something happens to trigger this pathway into action. Cyclooxygenase 1 pathway, this pathway we see in all sorts of day-to-day normal body structures like blood vessels, stomach, and kidney, in case you didn't read it. Cyclooxygenase 2 pathways are induced by cytokines and mediators of inflammation. So in other words, COX-1 pathway is going on all the time. COX-2 pathway is much more localized to pain. So just common sense would suggest that if we are trying to control pain, that we really would want to target COX-2 pathways. So hopefully this helps make it a little bit clearer. Physiologic stimuli, physiologic anything is normal, right? So just in the normal course of day-to-day body function, you will have cyclooxygenase 1 present. It is converting prostaglandins into other compounds, and what's particularly clinically relevant are the actions of COX-1 in the gut, in the kidneys, and in the platelets, right? So cyclooxygenase 1 will stimulate in the stomach or in the intestine production of prostaglandin E2, which is really important in developing the, the bicarbonate barrier that protects the intestine, the lining of the intestine, from the acids in it. So we haven't talked about GI drugs yet, but just remember basic gastrointestinal physiology. In the gut, you've got a highly acidic environment, right? And in order to protect your own gut lining from its own acid, we typically make this bicarbonate mucosal layer that buffers the acidic contents of the gut from reaching the actual lining of the stomach and small intestine. An important part of making that layer is prostaglandin E2, and we need cyclooxygenase 1 to make that happen. We also, in the vascular endothelium, cyclooxygenase 1 will trigger the production of thromboxane A2, which is It's a compound that helps us clot. It's something that helps activate platelets because we all have to clot on a day-to-day basis. I mean, you and I right now are experiencing some sort of intravascular little microscopic damage, and then we'll make a little clot and that'll protect us and life will be awesome. At the same time, in the kidney, we are making prostaglandins that help perfuse, that help with nephron perfusion, that facilitate the excretion of wastes and filtration through the nephron. So cyclooxygenase 1 is a compound that is critically important to maintaining normal function of the gut in making its protective layer, in the blood vessels and allowing us to clot normally, and in the kidney to promote optimal renal perfusion. That's COX-1. COX-2 is induced by those products of cellular injury, like potassium ions and acid and histamine and substance P and all of those other things I said get leaked out of injured tissue, right? So logically, if we want to decrease the ability of type C fibers to transduce those chemicals into a nerve impulse, we want to block the action of COX-2. So I'm going to put a big red X on it. That's why when we have some sort of injury that can be expected to produce cell death and the liberation of intracellular chemicals that will stimulate type C fibers, if we give a non-steroidal anti-inflammatory drug, it will block the production of COX-2. It'll where I just put the big red X, and then you won't get pain, basically, right? So that would be awesome. The problem is that the overwhelming majority of anti-inflammatories like Motrin, Aleve, Toradol, and everything else block both of them. So you get big red X's on both of them. So when you give this drug to block the inducible COX-2, you also inadvertently block the constitutive COX-1. So yeah, your pain will be improved, but you may not be able to clot effectively, you may not have good renal perfusion, and you may not be able to form that protective barrier in your stomach and intestine that's going to protect you from your own acid. Get where we're going with this? This is why several years ago, somebody thought it would be awesome to produce a selective COX-2 inhibitor. So we'll draw a big red circle around that to emphasize how awesome it would be, except that there were other issues with that and some of those drugs fell off the market. So in the end now, all we have is Celebrex is the only selective COX-2 inhibitor on the market. I will point out to you that being selective for COX-2 doesn't make it any better. It doesn't relieve pain any better. COX-2 inhibitors aren't any better at pain relief than the non-selectives. It's just that they spare those other parts of the body. So these are indicated for things that can produce those chemicals that will activate type C fibers. Non-steroidals, what they do is block the activation of type C fibers by those intracellular components that are liberated when there is cell death, mostly prostaglandins, right? So they're indicated for inflammatory disorders like musculoskeletal issues, sprains, strains, arthritis is what I'm trying to get at. Chronic pain due to inflammation, all sorts of inflammatory conditions out there for which non-steroidals can be effective. However, the side effects are that while you block the induced cyclooxygenase 2, you will inadvertently block cyclooxygenase 1. So there is the potential for increased risk of ulcer development because you can't make that protective barrier in your gut. There is the potential for bleeding because your platelets won't aggregate as effectively. And then there's other things here like prolonged gestation because you need prostaglandins to make your, uterus contract when you're in labor. And we said that you need prostaglandins for optimal nephron perfusion. So if you give nonsteroidals to somebody, you may inhibit their renal function. And vasomotor rhinitis, for some reason that I can't explain to you, but there is an association there with chronic nonsteroidal use and chronic like clogged up nose, but I don't care so much about that. What I do want you to know is that when you give people nonsteroidals, it really can interfere with the ability to make that protective barrier in the gut. It can interfere with your ability to form a platelet plug, and it can interfere with your ability to maintain optimal renal perfusion. If somebody already has some renal dysfunction, like stage 2 chronic kidney disease, nonsteroidals really can put them over the edge. And it really, take it from one who knows. We all learn best from the mistakes we made. You really can markedly exacerbate somebody's renal failure by giving them a nonsteroidal, which will inhibit the function of renal prostaglandins. Let's see, some drug interactions here, mostly related to their action, like, potentiates anticoagulation because it blocks natural ability of your platelets to do their thing. Increased lithium and methotrexate toxicity, mostly because those drugs have narrow therapeutic margins. And so if you impair renal function in any way, there's a potential for toxicity for anything that can that relies on renal excretion. And then reduced effectiveness of antihypertensive because, among other things, nonsteroidals do block some of the prostaglandins that produce vasodilation. So these can contribute to vasoconstriction. Again, take this from somebody who knows firsthand. If you're trying to get somebody's blood pressure under control and you just can't figure out what's going on, find out if they're eating Motrin all day long. People that take like 2 and 3 different doses of Motrin a day for chronic arthritis or something, it can really impact your ability to get their blood pressure under control. And then finally, watch for hyperkalemia, again related to the decreased renal efficacy. The impact on renal function cannot be understated here. Again, it's always a risk-benefit analysis. I mean, sometimes you will need to give nonsteroidals to people who have some renal dysfunction. In fact, I had this conversation very recently with a nephrologist because I think I mentioned in another slide set, I only have one kidney. So it's a good kidney, but I only have one. My GFR is like somewhere around 50. So for somebody who used to eat Motrin all of her life for migraine headaches before I only had one kidney, when I found myself with one kidney, I was like, oh crap, I need to find out about this. And one nephrologist said to me, absolutely under no circumstances should you ever take a nonsteroidal again. And I was like, I didn't like that answer, so I found another nephrologist who told me what I wanted to hear, which was, once in a while, like once a month, once every couple months, you need to take some Motrin for a headache, go for it, but absolutely not on a regular basis just because of the impact that it can have. So there really is a distinct relationship between giving nonsteroidals and decreased renal function. Acetaminophen is another it's in the anti-inflammatory family. I'm sure you've been told 100 times over that it's not the same as a nonsteroidal. In fact, people who can't take nonsteroidals, like yours truly, had to learn to develop a loving relationship with acetaminophen. It's definitely not as effective for pain management as anti-inflammatories are, but it does have some role. So how acetaminophen works has actually been a pretty popular topic of conversation. It also inhibits cyclooxygenase, just not nearly as effectively as your traditional non-steroidal anti-inflammatories. There is a whole contingent that theorizes there is a third cyclooxygenase pathway. Interestingly, acetaminophen is much better at suppressing fever than it is in controlling inflammatory pain. Anybody who has chronic inflammatory pain will tell you acetaminophen is not nearly as effective. I will tell you though, part of the secret there is to take it as soon as you start to experience the first twinge of pain. This is critically important. It really can be helpful, but yes, it's not as abrupt. It's not as profound as a COX-2 inhibitor. So anyways, some people call it a COX-3 inhibitor. Other data, like your slide says, suggest that it is just extremely, extremely highly selective for COX-2. Either way, it is an option that is much more sparing to the kidney, and that's what's important. So if you have somebody who really does have renal concerns and you really need to back them off on a non-steroidal, acetaminophen is not great, but it's better than nothing. It's your next best bet. So this picture doesn't really have much to offer that I just didn't say, except to illustrate that there is a school of thought that thinks perhaps acetaminophen is just highly selective for COX-3. So, to summarize, anti-inflammatory medications, their point of impact here primarily is inhibiting the transduction of type C fibers, right, of chemical pain being transduced into a nerve impulse by way of the type C pain receptors. Most anti-inflammatories out there are nonsteroidals, and they block both COX-1 and COX-2, induced and constitutive, which will give you good pain relief, but the unfortunate side effects that we talked about. COX-2 inhibitors are, let me get a different color here. COX-2 inhibitors are, well, Celebrex is really the only one, will only inhibit COX-2, so you see it's supposed to be a purple X. So you get inhibition of cyclooxygenase, but sparing of the GI and the renal and the, to some extent, the bleeding side effects. And then acetaminophen, which is perhaps your COX-3 inhibitor, however you want to call it, that only blocks this end of the spectrum. And you can see pain to some extent, but fever. Acetaminophen really is, its claim to fame really is fever reduction. But the nice part about it is acetaminophen, you don't have any of that suppression of COX-1. You don't get any concern about the gut, the ulcers, the renal function, or anything like that. Now, like everything else, you can most definitely take too much of it. If you take way too much acetaminophen, then the concern you've got is for liver toxicity. We got a big red circle here. So, the bottom line is everything in moderation. But if somebody's got like a real kidney problem, I'd forget the nonsteroidals and go with the acetaminophen. If somebody's got a real liver problem, then I'd skip the acetaminophen and sparingly use the nonsteroidals. And if they have both a liver and a renal problem, well, then maybe you got to go to an opiate, which is the next topic of conversation. So now it's time to talk about the opioids. Well, again, like the slide says in front of you, their mechanism of action is that they bind to mu receptors. So what does that mean? Well, mu receptors are abundant in that pathway from the third ventricle down, right? So opioids actually are a synthetic way of activating those enkephalin and serotonin receptors. Opioids are basically synthetic enkephalins. They have that same mechanism of action where they block the ascension of pain impulses from the spinal cord up. So they are very effective in the management of pain. They stimulate those nociceptive or pain receptors that are transmitted from those paleospinothalamic and neospinothalamic pathways, and they inhibit the ascension of those reflexes at several points, ultimately blocking or interfering with their ability to make it to the brain, right? So again, a pain impulse only hurts if it gets to the brain. This, what does your handout say? Profound analgesia can be produced. Yeah, I mean, if you happen to shoot morphine right into somebody's third ventricle, it really does control your pain. The opioids, the early studies in documenting efficacy of those were exactly that way. Opiates were instilled into the third ventricle of dogs, actually. A lot of these studies were done long before there was an institutional review board that would protect them. That's how we know it works. So opioids, again, are synthetic forms of enkephalins. In the earliest studies, way back before anybody was really regulating it, we knew this because scientists would instill opiates into the third ventricle of dogs while they were under a paralytic anesthesia and blah, 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 and would measure mechanisms of like the physiologic markers of pain, like tachycardia, respiratory rate, stuff like that. Opioids, so they really are good. The problem is, just like any synthetic neurotransmitter, any synthetic anything that we make, synthetic hormones, it's never quite as pure as the natural one. So while opioids definitely are good at suppressing the ascension of those pain impulses, they have some other actions as well that cause the adverse effects that we're familiar with. So number one, directly suppressing respiratory centers in the brainstem. So obviously one of the concerns about over-medicating with opiates is, yes, you will definitely control pain. I mean, you can give enough morphine or morphine equivalent to control somebody's pain, but if you give too much, you will suppress their respiratory centers too, and then it kind of defeats the whole purpose of the thing. So next slide. Many decades and decades ago, somebody came up with the notion of combining opiate receptor, mu receptor agonist and antagonist in combination pill form. Talwin, Nubane, these are all really old school pills. Nubane, if I remember, I mean, I think that predates me. If I remember correctly, that was an inhaled pain medication that was used for migraine headaches. Butorphanol used to be marketed as Stadol. It's no longer even available in branded form. I understand that butorphanol is still used in labor and delivery because for whatever reason, the opiate piece of butorphanol doesn't, it's considered comparatively safe when it comes to not suppressing uterine contractions and stuff like that. So you do have these agonist-antagonist combinations out there. The top three were very, very old. Once upon a time, somebody came up with the idea that if you gave an agonist and an antagonist in the same pill, then it would be impossible to overdose on them, that you couldn't get respiratory depression. That didn't work out so well, so nobody made new ones for a long time. You know, these drugs are around. I know people still use butorphanol, like I said, in labor and delivery. I don't know about these other two. I have never seen them used in clinical practice, and I've been an MP since 1993, both in the in and outpatient setting. Now, Embeda is newer. Embeda, you know, interestingly, Talwin, Nubane, and Stadol were initially formulated to protect the patient from adverse effects. Embeda wasn't put together for that reason. Embeda was developed with morphine and naltrexone center, the idea being that you couldn't crush this or snort it. One of the big problems with opiate analgesia is that people crush the pills and then they inject it, snort it, like all kinds of ways to try to get it to the brain faster. And the idea is with Embeda had naltrexone embedded in its center. So if you tried to crush it, you couldn't abuse it, basically. So unlike the first three, which were developed as combinations for the patient safety, the last one here was developed to try to inhibit the ability to abuse it. From what I understand, it just never really caught on. And I also understand that in some settings out here on the western or, you know, the more rural part of the country, people have found a way to abuse this too. So I don't know if you've ever seen it prescribed. I believe it is still available, but it just never caught on because it wasn't as effective at preventing crushing, snorting, injecting as it was supposed to be. So the more contemporary opiates that are developed, we just keep trying to find a way to control the pain while decreasing the ability for abuse, addiction, dependency, and adverse effects. Opiates as a general class, their mechanism of action is really that they block, that they are mu receptor drugs and they block the ascension of those pain signals like we were talking about earlier. Like I said, it's never as good as the pure form. We can never make anything as perfect as the body makes it. And so there are other consequences here. Opiates do depress the cough center in the medulla. And for that reason, some opiates have found a little niche in being the key component in prescription cough suppressants. It's funny, in all the clinical classes that you'll have, everybody will tell you that cough suppressants are like the last class of medication you should use to treat somebody with cough. And yet in day-to-day clinical practice, they are very commonly used because they do suppress cough. In some circumstances, opioids can also have the undesirable effect of stimulating the chemoreceptor trigger zone of the brain. We haven't talked about the chemoreceptor trigger zone. I mean, maybe you did in physiology. I hope you did in pathophysiology, but we will revisit it again when we get to GI drugs because the most effective antiemetics are those that suppress the chemoreceptor trigger zone. When you stimulate the chemoreceptor trigger zone, you stimulate the vomit reflex, and opiates can do that. So that's another one of those, unpleasant adverse effects. Notice your slide says nausea and vomiting rarely occur in the recumbent patient, suggesting that there is a vestibular component. So taking opiates and being ambulatory is more likely to increase the risk of nausea and vomiting. The patient who is bedbound, like say the post-op patient, they're less likely to have nausea and vomiting as a consequence of opiate administration. So again, they bind mu receptors, and when they bind them in that pathway in the brain, they very nicely block the ascension of pain impulses. However, like I said, they're not pure and they will bind mu receptors elsewhere in the body. We do have mu receptors all over, for instance, the intestine. You can see on this slide, we have mu receptors from top to bottom in the intestine. And if you give an opiate, you're going to bind mu receptors and ultimately decrease hydrochloric acid secretion in the stomach. So that decreases the ability to digest well, because hydrochloric acid is critical to the mixing of the food bolus and preparing it for translation through the rest of the gut. So binding mu receptors with opiates will decrease that. It will also decrease other digestive enzymes that are secreted by adjunct organs like the pancreas, etc. Also, binding opiate receptors enhances non-propulsive contractions, which is sort of counter to having passing food along the gut or having a bowel movement. In the gut, you have non-propulsive and propulsive contractions. Muscle in the gut, muscle everywhere for that matter, is always on the move. And so even if you don't eat anything and have no bowel movement to prepare, you will have non-propulsive contractions. Then as you ingest food boluses, your body prepares to have a bowel movement, you will have propulsive contractions to empty your large intestine. These drugs enhance non-propulsive contractions while simultaneously inhibiting propulsive contractions. So you can see how this all comes together to make people like constipated, which is opiates are notorious for that. First, you don't have enough acid to digest properly. Then you don't have enough digestive enzymes to digest properly. Then you're going to step up your non-propulsive contractions, inhibit your propulsive contractions, and then finally, if the waste bolus does make its way all the way down to your rectum, these drugs actually augment tone of the anal sphincter. They make it harder to relax your anal sphincter. So opiates just have constipation written all over them, from the top of the gut to the bottom of the gut. Again, risk-benefit ratio. Sometimes you have to use them, but always be aware of the adverse effect profile. Other actions, and so now we're talking more about abuse, obviously. Actions on the healthy, pain-free adult. We know that opiates, whether it's oxy, hydrocodone, heroin, methadone, hydromorphone, pick your opiate, will produce drowsiness, nausea, and vomiting for all the reasons we just mentioned, like nothing's moving forward in the gut. Apathy, and this is a central nervous system phenomenon. Also, notice that there is no significant effect on healthy myocardium, but in cardiac disease, morphine, and this is pretty specific to morphine, it's not unique, or it's not common to all drugs in class, but unique to morphine is that it will decrease oxygen consumption and myocardial workload. I feel like we actually talked about this when we were talking about cardiovascular drugs, that in the acute CHF patient, these morphine actually really does relieve myocardial workload, decreases consumption, and helps control pain and anxiety, unlike many other opiates out there. So, again, risk-benefit ratio, that's all it comes down to. Other adverse effects related to the things that it does. So nausea, vomiting, constipation, we talked about it. Urinary retention, because you can't contract your bladder. The muscle just won't contract. Mental clouding, because of that impact on the central nervous system. Dizziness, hypotension, these are all a consequence of their impacts, not just on the central nervous system, but the vasculature as well. So risk benefit. So that's like generally as a group, the opiates. Remember, we started this discussion by saying the opiates are very effective with respect to pain control. You just need to consider these adverse effects and then, decide risk benefit. Is it worth it? Is there anything else you can do? Also recall that we talked first about nonsteroidal anti-inflammatory drugs, which inhibit transduction, specifically of type C fibers, because the nonsteroidals block the ability of some of the chemical triggers or chemical stimuli that will activate type C fibers, whereas these drugs, the opiates, block transmission. They block the ascension of the impulse to the brain. Now there are some specifics here. Tapentadol, Nucynta is a drug, and again, you may or may not be familiar with this. Nucynta is a synthetic opiate. It's a synthetic mu agonist. The thing that's different as compared to the hydrocodones and the hydromorphones and the oxycodones is that in addition to an opiate agonist, it is also a norepinephrine reuptake inhibitor. Remember when we were talking about antidepressants, I alluded to the fact that norepinephrine reuptake inhibition could help with neuropathic pain, and does, like the antidepressants that have norepinephrine reuptake inhibition components are commonly used for neuropathic pain. One of the theories of neuropathic pain, I don't know if it's in here or not. One of the theories of neuropathic pain is that chronic ongoing pain or chronic nerve injury will alter the way that those receptors perceive stimuli. It alters the receptors, basically. The type C fibers or the type C receptors and the type A delta receptors, they're just nerves. And there is a theory that after a time, especially after a certain exposure to pain over the long haul, those transducers actually morph. They become abnormal and the threshold lowers, so they're more readily stimulated to a pain impulse. There is a belief that a norepinephrine reuptake inhibitor can help attenuate that. So that Nucynta isn't just an opiate or a mu agonist, it's also a norepinephrine reuptake inhibitor, and it comes in extended release forms. Now, I think when we get toward the end of this discussion, we'll talk about long-acting opiates versus short-acting opiates. Tramadol is a different type of mu opioid agonist. It isn't pure, it isn't, what's the word I want? Oh, God bless it. Literally, it's not literally an opiate in the literal sense of the word, but it does activate mu receptors. Ultram, the brand name for tramadol, was originally synthesized, a couple decades ago now, to try to be a good alternative to people that needed pain control by activation of a mu receptor, but for whom you were concerned about traditional opioids. So it is a weak mu opioid receptor agonist, but it is also a norepinephrine reuptake inhibitor and potentiates serotonin release in that area of the brain that we talked about, where there's serotonergic neurons release serotonin that go down the spinal cord to block the ascension of those pain impulses. There was a time when tramadol was considered a much safer alternative. It was considered non-addictive. We know now that that's actually not the case. It can produce a physical addiction. It's not as profound as your classic opiates like oxycodone, but it can occur. And the fact that it was given out so readily as an alternative to oxycodone years ago resulted in widespread use. And now we know that it actually alters the seizure threshold, like it lowers the threshold so that it's easier to respond to seizure stimuli. So bottom line is the use of seizure is higher in these drugs. And so once upon a time, we thought that they were really great and really safe. And now one of my colleagues, a pain management physician here in town, just flat out will not prescribe these. He'd rather have people on oxycodone or hydromorphone than have them on Ultram because of that seizure risk. So Hysingla ER is a long-acting form of hydrocodone. You're probably familiar with the short-acting forms of hydrocodone, Vicodin, Norco. Those are the two immediate ones that come to mind. Vicodin and Norco are hydrocodone along typically with an acetaminophen or a nonsteroidal. Percocet is oxycodone along with aspirin, and then Percodan is oxycodone along with an nonsteroidal anti-inflammatory. So there's lots of combination agents out there. But Hysingla is a little bit different. It's not a combo agent per se, but it is a long-acting drug that cannot be chewed or crushed. Notice we'll form a thick gel that can't be injected. Really, later forms of opiate synthesis really targeted finding a way for people not to abuse this. So I will say, I mean, even though it's kind of outdated now, but for a very long time in the world of pain management, we were advised, by the World Health Organization and JACO, like all of the authorities that advised us on pain management, we were advised that if somebody needed to be on opiates for the long haul, we should use a long-acting opiate. Rather than giving somebody Norco 4 times a day, we should give them Hysingla once a day. And the rationale for that is that there's a difference between pain control and euphoria. And opiates can produce both of these. They can produce pain control by blocking the ascension of those neurotransmitters, but they also cause a post-dose euphoria that is more a consequence of big serotonin rush. So the idea was that people would use these drugs because of the euphoria that they would get after taking them. So the goal was to find opiates that didn't produce post-dose euphoria. And that's where all the long-acting opiates came from, like Hysingla extended release. What was the other one we looked at? Nucynta, which is Tapentadol extended release. This actually was the genesis of OxyContin way back in the day, which is a long-acting form of oxycodone. The whole goal was, if you have to be on opiates for the long haul, get them on a long-acting opiate to decrease abuse by decreasing post-dose euphoria. Also, if you're on a long-acting high, like if you have malignancy or something, and you're on a long-acting opiate and you just take it every day, you have more of a steady state pain control rather than the multiple peaks and nadirs that occur when you take pills, 4 and 5 times a day. In the last, I don't know, like 2 or 3 years, with all of the attention to opiate addiction and opiate overuse, we've really been advised as a discipline to pull back from the long-acting stuff, basically because nobody wants us prescribing this for the long haul, period. It's all about short course of opiates to get somebody through the acute pain phenomenon and then get them onto some non-pharmacologic or injectable steroids or something like that. This is an example of the pendulum swinging too far in the other direction. I was just in August, what is this, October? In August, I was at a opiate symposium, a 2-day opiate symposium here in town, and lots of different sessions, not just on opiate abuse, but also on how to appropriately manage pain with opiates. And I was talking with one of the pain management specialists here about this, and he said, yeah, I know, he said the current trendy thing is to only use short-acting opiates for a short course. But for those people that really do need long-acting opiates, and for all of you, you may or may never come in contact with them, but there is a population of people that do need long-acting opiates. One that you can probably all identify with are patients with malignancies. They may live for a few years, but need pain management on a consistent basis. Long-acting opiates really are designed to provide, number one, a steady state of pain control, and number two, reduce post-dose euphoria. Oh, so rather anticlimactically, I guess that's the end of the opiate discussion. There are 2 more classes of medications that are generally regarded in the pain management world here. Those are the antidepressants and the anti-epileptics. I feel like we probably talked about this in the depression week, but if we didn't, antidepressants, those that have norepinephrine reuptake components like SNRIs, tricyclic antidepressants, they are very commonly used for long-term pain management, especially to try and eliminate or at least reduce the amount of opiate we have to use. Notice the first bullet point, mechanism of action is not well defined. There are those who believe that they stabilize the free nerve endings and can inhibit transduction. There are other authorities who assert that they have a more central action in that, remember that the functional areas of the brain that control mood are there in the pons between the spinal cord and the thalamus, where those pain pathways go. And there is a belief that by altering neurotransmitter concentration in the pons, you can alter the continued conduction of pain. So how it works entirely, I can't tell you 100%, but I can tell you that antidepressants that have a norepinephrine component are effective in attenuating pain, especially neuropathic pain or pain of a nerve origin, like, say, shingles. So, I already said this. I got excited and said it ahead of myself here. SNRI, tricyclic antidepressants, yes, all used for pain management. Again, SSRIs, not effective. There have been numerous studies that tried to document some efficacy for the SSRIs because, remember, they're the safest ones of the bunch. So we like SSRIs. They're safe. We don't mind giving them to people. And so there have been several studies that tried to document their efficacy in attenuating neuropathic pain. They don't. If you're giving an antidepressant to a patient with chronic pain, or you're giving it for the purpose of pain control, you want to go right to an SNRI, serotonin norepinephrine reuptake inhibitor, or a tricyclic antidepressant. And then the anti-epileptics, these are the last drugs that fall into the very generic general category of pain management. Chemically, they are very similar to tricyclic antidepressants. But their primary mechanism of action is believed to be the potentiation of GABA, which is inhibitory, and inhibition of glutamate, which is excitatory. So a similar chemical mechanism of action as they have in controlling seizures, right? But I will, you'll read lots of different things that really vary on this. Like antidepressants, we don't really know if they block the ascension of pain of more of a brain act or if they are stabilizing those free nerve endings. This is for the brilliant experts to figure out. All we know is that there are certain antiepileptics that really can decrease the amount of pain that patients feel. Again, primarily neuropathic pain. So there's some pain that is neuropathic in its genesis, like shingles, right? Shingles is herpes zoster, and I mean that is neurological from the time it starts. And antiepileptics are really very effective for that. There is also the belief that if people suffer acute or even like acute pain that's not well managed or chronic pain that is not well managed and goes on too long, it will eventually cause anomalies of those free nerve endings and a neuropathic component will develop. So even somebody whose pain is purely inflammatory, like say rheumatoid arthritis or osteoarthritis, that starts out as totally inflammatory pain. But if it goes on too long, untreated or inadequately treated, there is a belief that ultimately those nociceptive nerve endings will morph and then you will develop a neuropathic component there, which is why you see these drugs used for all sorts of pain. So pregabalin is Lyrica. I don't know why I thought to call it out here. I mean, pregabalin is Lyrica. Gabapentin is Neurontin. Topiramate is Topamax. Even phenytoin, Dilantin. Carbamazepine, which is Tegretol. Lots of these are used for pain management. Neurontin seems to be very commonly used. I will remind you that Neurontin for pain control really needs to be at fairly high doses. Lots of times when you see people tell you that Neurontin didn't work, it's because nobody escalated the dose appropriately. So again, these are the kind of things you'll get more information when you get to your patient management courses, but don't be surprised when you see these used for pain management. It is very common, and because it doesn't have the addiction potential of the opiates, these are becoming more and more in vogue. So just as a very general guide, again, your experiences and further education, they will all create the approach that you use for patients, but just as a very general rule of thumb, when you're treating somebody for pain, the first thing you ask yourself is it acute or chronic? Acute pain, there are definitions of this. Again, I'll leave that to your clinical instructors to fill you in perfectly. I think acute pain by definition is like less than 3 months duration or something like that. But we generally think of acute pain as an acute phenomenon in direct response to some injury, right? The only question here is it moderate or severe? Because if it's mild acute pain, it's probably not going to come to your attention as a healthcare provider. Patient will just stay home and take a Motrin or something. But if it comes to your attention, the question is it moderate or severe? Moderate acute pain, we really should start with a nonsteroidal. There are some very powerful ones. Most of you are probably familiar with Toradol. The generic name is Ketorolac. This stuff is amazingly effective and doesn't have the adverse effects or addictive properties of the opiate. So for moderate acute pain, consider a nonsteroidal like Toradol first. Now, if that doesn't do it, if it doesn't help the patient, or if it's contraindicated, like the one kidney person, then you would go right to an opiate, or the kidney disease person, you would go right to the opiate. On the flip side, severe acute pain, give them an opiate. This is your post-op abdominal procedure. Like, don't say, here, have some Motrin, it'll be fine. These acute things, like a femur fracture, a bone is protruding from a body part, a hip fracture. These are people, they just need opiates. Now, you can augment it with a nonsteroidal to try to approach another mechanism of action so that you don't have to give a ton of opiates. And that's what the things like Percocet, Norco, Vicodin, they are all opiate anti-inflammatory combinations. But for acute pain, moderate, try a good nonsteroidal first. If it doesn't work, or if the pain is severe at the outset, just give an opiate for a few days. Chronic pain is the real issue here. Chronic pain. So when you see a patient with chronic pain, you want to ask yourself, is this visceral pain, neuropathic pain, or musculoskeletal? Because those are the most common etiologies of chronic pain. Visceral pain, I'm talking visceral organ, like cancer, very commonly comes to mind here. Give them an opiate. I mean, if it hurts, give them an opiate. You know, if I have colon cancer or lung cancer or whatever, and I'm in pain, give them an opiate. Augment it with a nonsteroidal, because if you can decrease the amount of opiate and still do the job effectively, that's awesome. If, however, the pain is neuropathic, and again, I always use shingles because that's the immediate thing, but there are other forms of neurologic pain out there, and migraine, for that matter, as you'll see when we get to the next few slides, is a neurologic problem. Start with an anti-epileptic drug. Unless you can't, and then start with a selective, with a serotonin norepinephrine reuptake inhibitor. You can see those are your two options there. For neuropathic pain, before you even go to the opiate, try those drugs that treat neuropathic pain first. And if the pain is musculoskeletal, if it is inflammatory, if it is rheumatoid arthritis, osteoarthritis, that kind of stuff, start with a nonsteroidal. And there's a ceiling dose there. There does come a time where you dose out on the nonsteroidals. And of course, you always have to consider, the renal thing, the other contraindications. If you can't get good pain control with a nonsteroidal, add an anti-epileptic or an SNRI, because chances are there is a neuropathic component. And then for all of these, I mean, you just keep going. Like if there is, like rheumatoid arthritis, if they just can't get relief with a nonsteroidal and an anti-epileptic drug, sometimes they need opiates too. And sometimes neuropathic pain needs opiates. The thing about the opiates, remember what we've said in other slide sets here, the more effective the drug, the more likely the adverse effect profile, and nothing is any different here. The nonsteroidals, the SNRIs, these adverse effect profiles are much more favorable, but sometimes they're just not as effective. The opiates are the one that we know will help attenuate pain of any cause, because they mimic those mu receptors. So sometimes you just have to do it, but this is just a reminder that often you have other options. Now, just a few comments about migraine pain before we leave the slide set, because it is rather unique and there is a whole body of science emerging about migraine that's really very interesting. First thing, rather than trying to replicate what somebody else did and not do it as well, this is one of those rare times, it may be the only time, that this external site is a required viewing. There may very well be quiz or final exam questions from it because it's just so useful. It's linked here, and then there's also a link to it in the external reading sections, but I decided if I was going to require it, it should be here. This is an 18-minute video that goes through the contemporary thinking about the pathophysiology of the pain, of migraine pain, and it lays the foundations for the drugs that we use. Pay particular attention to the discussion of how migraine pain triggers the trigeminal nerve and the various branches of the trigeminal nerve, where they terminate, where migraine pain is. I mean, it really is sort of a different look at migraine pain. You'll also notice, and they mentioned this somewhere like around minute 6 or minute 8, they mentioned in the video how sinusitis or sinus inflammation is very often confused with migraine pain, and that for years and years there have been patients whose pain has been attributed to sinus inflammation or chronic sinus problems, and it really turns out that it's migraine, and people don't believe it. And so if you know what you're talking about when you try to explain it, it's much more effective. And you'll see from this video how there is a branch of the trigeminal nerve that deposits itself like right in the sinuses, so the pain of migraine may be almost like really identical to the pain of sinuses. And the other thing that's interesting is the reflex parasympathetic trigger, which will cause things like nasal discharge, eye tearing, and those are symptoms that people frequently associate with sinusitis. And now we know that it's a parasympathetic consequence of migraine. So it's really interesting how with migraines, and again, most of this will come to you in your clinical classes, so I'm not trying to jump the gun here, but of course, diagnosing migraine is always like the first challenge in treating it properly. This video really gives you some good insights to that, and it really details for you how some of those underlying neurotransmitter and inflammatory mechanisms are present. So the theory that you see presented in this video really is the foundation for contemporary pharmacotherapy. And the gist of it is, like we've always known that there are alterations in cerebral blood flow during a migraine event. Like this is well documented. We know that there's changes and that there like first there's a period of constriction and then there's a period of dilation, and pain sensitive cranial arteries will dilate and there's increased blood flow. How that happens to those arteries is really the thing that is evolving in study. And that's what it is that we're trying to treat. And we know now that once you get to that place where you've got the profound vasodilation and this pounding pain, it's really much harder to get a handle on the pain. One of the most important things we know with contemporary approach to migraine management is that we are trying to reduce the inflammation or trying to reduce the potential for vasoconstriction very early on. So when you look at all of the options here, in the world of migraine, we have abortive therapy and prophylactic therapy. Abortive therapy, just like the slide suggests, this is what do you do after the patient develops a migraine. So when you look at these drugs here, the one thing that they all have in common is that they cause vasoconstriction. Yes, nonsteroidals do inhibit inflammation. They suppress inflammation, but ultimately they contribute to vasoconstriction. Remember how we said with antihypertensive drugs that nonsteroidals can block that action because nonsteroidals can contribute to vasoconstriction. Isometheptane, I think that was marketed as Midrin. I don't even know if it's available like that anymore. Ergotamine, all the triptans, sumatriptan and all the little baby triptans, these are all vasoconstrictors. Dopamine antagonists, these are basically your second generation antipsychotics. They also will cause vasoconstriction in the brain. And dihydroergotamine mesylate is DHE commonly. This is a very profound vasoconstrictor. All of these are vasoconstrictors, and we all know that to some extent or the other, they can improve migraine pain. Nonsteroidals and Midrin, this is like if you get it when it first starts as an outpatient, sometimes that'll help. The triptans are generally our go-to rescue drug. I mean, ergotamine is also very effective. It's just that the vasoconstrictive piece of it can produce its own problems. But the triptans are really sort of like the gold standard for abortive therapy. Second generation antipsychotics are like when nothing else is in the outpatient world works, and DHE is like a headache center in maybe not inpatient, but if you're in the headache center under supervision. I've known that to cause MI, so that's no joke. That's for the patient who's in the headache center, can't get any relief with anything else. If they're a safe candidate, you would give them DHE. But the one thing all of these have in common is that they are vasoconstrictors. That's what abortive therapy does. Like I said, we've always known that there was a relationship with migraine pain and blood flow. What's really the subject of conversation now is that antecedent phase, what produces that anomaly of blood flow. That's why we've got some new prophylactic therapies on the horizon and some old ones too. So prophylactic therapy, they fall under the general categories of CNS neurotransmitter modulators and CGRP inhibitors. So CNS neurotransmitter modulation, that's what we have here. These all try to attenuate those things that will cause vascular change. Beta adrenergic antagonist, right? They block vasoconstriction. The belief with migraine pain is that something happens to cause vasoconstriction that will then produce rebound dilation, which is where the pain comes from. So ideally, we want to get that before it happens. We want to precede the vasoconstrictive piece so that there will then be no vasodilation piece and there will be no pain. So here we're trying to control constriction. Beta blockers, tricyclic antidepressants, both of these drugs will attenuate vascular tone, right? They keep you from constricting so that you can't rebound and dilate. And they are historically your first line agents. Beta blocker, the classic one is Inderal, right? Inderal is the brand form of propranolol, 40 milligrams BID, has really been an effective prophylactic migraine therapy for as long as I've been around. I mean, it totally doesn't completely decrease the likelihood of migraine, but it can reduce your migraine days. I mean, over the years, I've seen Inderal change people's lives that had migraines. Doesn't cure them, doesn't make it completely go away, but it really can help. These drugs, however, beta blockers and tricyclic antidepressants, both do have a side effect profile, which takes you back to that, risk-benefit phenomenon. In more recent times, Next slide. More recent times, we have a newer emergence in the world of migraine prophylaxis, and these are your CGRP inhibitors. There are 3 currently on the market, and they have really interesting names: Aimovig, Ajovy, and Emgality. I don't know who comes up with that stuff. You'll notice the one thing they all have in common is the suffix, right? MAB. These are all monoclonal antibodies, which really is the wave of the 21st century in terms of pharmacotherapy. The thing that makes them so desirable, these monoclonal antibodies, is the side effect profile is much less profound. So we know, I mean, I know because I read it, we know from observation studies that CGRP levels, inherent intrinsic CGRP levels rise during an acute migraine, and then they fall as the migraine resolves. This has been observed in migraine subjects. So the idea is administering antibodies can help precipitate or potentiate that fall. So if we can get to somebody and keep their CGRPs down by giving CGRP inhibitors, maybe we can suppress migraine. So these are prophylactic therapies. These are not meant to treat a migraine after it starts. That's what the triptans and the ergotamines and the nonsteroidals are for. But if you have somebody who's having like lots of migraines, and there are particular criteria for this, and I don't remember what they are off the top of my head, but something like if you have more than 15 migraine days a month, that's when these drugs are indicated. For people that do have migraines, like there is a whole psychology of, it's not just that they get a bad headache. They very often have a prodrome. Some will have an aura and some won't. But there is usually that prodromal sense that something is going to happen. You ask migraineurs, they'll tell you, they know when it's coming. Sometimes it doesn't come for a day. Sometimes it comes in an hour, but they usually have that initial twinge that something is coming. And then the migraine itself can last for hours or it can last for days. And then some people are really subject to a migraine hangover. So it can become a way of life. And then for some people, there are so many potential triggers here. Some people just live this cycle of anticipating a migraine, experience it, and recovering from it. And when you're having like 15 or more migraine days a month, truly anticipating the next migraine is as difficult for people sometimes as actually experiencing it. So drugs that are really effective with respect to prophylaxis, they're huge. There's a huge need for it. And these drugs, like I said, their claim to fame is that they really tend to be very, very favorable in terms of side effects. So much better tolerated, and they advertise reduction of migraine days by 50%. I have known patients to experience a 75% reduction in migraine days per month. It can be really huge. And look at the adverse effect profile. This isn't a beta blocker. It's not going to make you not be able to breathe if you have asthma or decreased cardiac output, or it's not going to cyclic antidepressant. It's going to make you tired all the time and orthostatic hypotension and all that. Maybe injection site reactions because these are injectable drugs. And again, sometimes we just don't know where this stuff comes from. Mild URI symptoms probably having something to do with that impact on the autonomic nervous system. But you know what? The occasional rhinitis beats the heck out of having migraines. So these are the up-and-comers. These are very pricey. If insurance covers it, it's definitely something to try for patients. Otherwise, they are many hundreds of dollars. But they're not necessarily a whole lot better in preventing migraine than Inderal, but they are much better tolerated. They're considered very safe. And this last slide here are some other medications that people use to try to prevent migraines. These are prophylactic therapy. So gabapentin, topiramate, valproic acid, you probably recognize these, and there are some others in class as well. These are used to try to prevent migraine. Sometimes we refer to them as GABA agonists. They actually potentiate the action of gamma-aminobutyric acid, which is an inhibitory neurotransmitter in the brain. The way they potentiate GABA is that they bind to these alpha-2 delta subunits, which inhibits, what's the best way to explain this here? By inhibiting these subunits, you allow GABA to work unchecked, basically. So loosely, we can say that they do potentiate GABA. They potentiate inhibition, which is another way to try to control migraines. And again, much more cost-effective It always comes down to the adverse effects. So I know I keep singing the same song, risk benefit analysis. The newer drugs, the CGRP inhibitors, they're just so well tolerated that if the insurance plan will pay for it, they're awesome. Other than that, we use some of the old school stuff, which is just as good. It's just that the side effect profile can be a little bit more troublesome. Not that that's, believe me, not that that's a reason not to use it by any means. Millions of people use the older school drugs very successfully. So anyway, that's it for this week. And please do watch that 18-minute video about the pathophysiology of migraine pain. And that's all I know. So see you next week.